Top Bed Talk.
EBPOM visiting professor for 2021 is Meghan Lane-Fall. Meghan is the David E. Longnecker Associate Professor of Anesthesiology and Critical Care and the Vice Chair, one of the Vice Chairs in Anesthesiology at the University of Pennsylvania. And probably of most relevance for this talk, she's the Director of Acute Care Implementation Research at the Penn Implementation Science Center. She has degrees from Berkeley and Yale and UPenn, so clearly moved around the States a reasonable amount, and is board certified in both anesthesia and critical care medicine at Penn. So I first met Meghan at a clinical trial meeting in Italy, where she's contributing to a really excellent meeting on women in medicine. She is a really exemplary role model in combining a really top-flight academic career with a whole load of other roles. And if you have a look at her website, she lists her 9 jobs, which she may or may not come onto, including mum and partner and administrator, leader, etc. Thank you so much for joining us. Meghan's going to talk to us, as you probably gathered now, about perioperative implementation science. Thank you very much, Meghan.
Mike, thank you. It's a tremendous pleasure and an honor to join you all to talk about something that is near and dear to my heart, and hopefully I'll help endear this field to you as well. I want to talk to you about perioperative implementation science and how it can help us achieve some of the goals that we set out to achieve as we take care of patients in and around the time of surgery. I have no relevant financial conflicts of interest to disclose. My work is funded by the National Institutes of Health in the United States, and I have some other relationships that are here on the slide, but nothing that represents a conflict. I have 2 objectives for the time that we have together. The first is that I'd like you to be able to explain where implementation science fits in the translational research spectrum. And I'd also like you to be able to, at a high level, describe the utility of implementation science for perioperative medicine research. I know that most people don't remember most of the presentations that they hear, and as much as I want to think that you'll take to heart everything that I say, it's likely that you won't remember much. So I have one important takeaway point for you. That there is a field that's devoted to developing and testing strategies to change clinician and organizational behavior, and that field is implementation science. So the main takeaway point from my remarks is that this is a thing, and hopefully you'll know a little bit more about that thing as I talk. So as we think about evidence-based perioperative medicine, as we think about clinical care in general, we can ask ourselves, what gets in the way of reaching our goals for clinical care? What gets in the way of us achieving the outcomes that we set out to achieve for our patients? One of those factors is access to care, and that's something that my mentor, Lee Fleischer, knows a lot about. One of those factors is knowledge, trying to figure out exactly what we should be doing and generating the evidence base to support our care. But a lot of times we have evidence and we just don't follow it. And that is the focus of implementation science. So it's not so much the creation of new knowledge about effective therapies, but it's trying to get clinicians and organizations to actually follow the evidence that we already have. There are many examples of us as clinicians, as health systems, not following evidence. And so whether that's doing too much of something, as we love to do in the States, we like to do expensive procedures that don't work, or whether we have evidence around, for example, protocol compliance, whether that's standardized handovers or whether that's enhanced recovery after surgery, we know that our clinicians don't always adhere to best evidence. So implementation science is really focused on bridging the evidence to practice gap. This is the entire point of this field. There are some estimates that it takes 17 years for 14% of findings to make their way into clinical practice. Those estimates have been updated, but there's still a significant gap between the discovery of new knowledge and the integration of that knowledge into clinical practice, and that's where we're focused here. The official definition of implementation science comes from the first edition of the flagship journal, Implementation Science, and the editors say that this field is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services and care. This is a reasonable definition. It's been my working definition for a number of years, but I have a more favored definition that comes from an implementation scientist named Ann Sales, who's based at the University of Michigan in the States. She says first we have to define implementation because it's a little bit of a fuzzy word. And so what she says is that implementation is a process of planned human behavior change under organizational constraints. Implementation science in health then applies the study of implementation and related processes to healthcare services and possibly secondarily to health behavior. And that parenthetical note here is a nod to the idea that we are really looking at clinicians, hospitals, health systems, care systems, and not so much at patients. There is a separate literature around changing patient behavior. A lot of it has to do with activation, with understanding, with literacy, with numeracy. And as important as that work is, it's a little bit tangential to what we talk about in implementation science. So really the focus in implementation science is on us, is on the providers of healthcare, and trying to figure out how to get us to change our behavior to comport with evidence. Implementation science is action-oriented and it's change-oriented. This is not purely descriptive work. This work is done with the intention of changing behavior. And so all of the literature around behavior change is what we marshal to do this work. So implementation science in the United States, and I think around the world, is conceptualized as translational research. So here I'm showing you an example of the translational research spectrum. If you ask the United States National Institutes of Health, they will tell you that the translational research spectrum goes from T0 to T4, where T0 is basic science research. You can think of it as pure research, clinical discovery just for knowledge's sake, just trying to understand how the world works, how systems work, how cells work, how physiology works. And that goes all the way through translation to humans, translation to patients, translation to practice, into where I sit, which is somewhere between the translation to practice and the translation to community. And that's really where implementation science is. All of the pictures that you see there along the bottom are actually folks in my own department at Penn. Lee is on there as well. And the reason that I do this is to show the world and to show my colleagues that we are all part of the same team. My favorite person to point to in this picture is in the top row all the way to the left. Her name is Vicki Bedell. She is a basic scientist who studies zebrafish. I have never seen a zebrafish. I could not pick one out of a lineup, but what Vicki does in zebrafish, understanding anesthetic mechanisms, will never reach a human unless I do what I do. And so implementation science you can think of as part of the last mile delivery of scientific evidence. And so it's an important part of the research spectrum. Implementation science is a blanket term that applies to a lot of related concepts. So dissemination research, which is research about how to get information to people and to systems, is part of implementation science. In Canada, they would call it knowledge translation. So how do we translate knowledge into practice? There are related concepts of implementation practice, which is not so much focused on building evidence around implementation, but applying best evidence, which is a little bit meta. There is implementation research, which is going to be the focus of what I talk about. And then increasingly, we're interested in de-implementation, which is the idea that we want to stop people from doing things that don't work. And what we understand now is that the process of implementation and the process of de-implementation are not exactly mirror images. It's sort of like the concept of hysteresis in anesthesia. You know, the concentration of anesthetic that it takes to get you to sleep is not the same as when you wake up. So it's not the same going and coming back, but we're increasingly understanding what we need to do to get people to stop doing things that don't work or to decrease the use of low value practices. Implementation science is a mutt. And I realize that we have a global audience here. So when I say mutt, I mean it is a combination of a lot of different disciplines. It is not a purebred discipline. It draws from many different other disciplines that have been around for a much longer period of time. One of those is program evaluation, which has a background in public health. We draw from psychology, which teaches us a lot about individual behavior change. We draw from community-based research and understanding the perspectives of the communities whose behavior we want to change. And we pull a lot from management science as well. I would argue that we also ought to be pulling from systems engineering and human factors engineering, which has a lot to say about workflow and how to structure workflow and how to understand it. And then increasingly, behavioral economics is being incorporated into implementation science. And this is the discipline that tries to understand how to change behavior based on what people's motivations are, and understanding that people's motivations and their behavior don't always match up. And behavioral economics in many ways tries to decrease the gap between what we say we want and what we actually do. An example here might be we want physicians to prescribe generic drugs because they cost less than brand name drugs. And physicians will often tell you, yes, I intend to prescribe generic drugs, but they don't, because the brand name drugs are much easier to remember. So a behavioral economics approach might change the default in a computerized ordering system so that it's easier for the physician to order the generic. It's more difficult to order the brand name. They can if they want to. Their behavior is not constrained. But you've changed the system, you've tweaked it in just such a way so that the intention and the behavior match up a little bit better. And increasingly in implementation science, we're learning how to do that. So who should care about implementation? This is a conference about evidence-based perioperative medicine. We've got folks interested in hemodynamics. We've got folks interested in outcomes. We've got folks interested in regional anesthesia. So who exactly am I talking to and who should care about implementation? I would posit that it's everyone, but I will walk you through that. So patients and families care about implementation because they want to receive the best quality care. In fact, I would argue that they assume that they're receiving high quality care. They know that we are experts. They know that we have trained to deliver high quality care. And so when they come into our clinics, when they come into our doors, they're expecting that we understand the evidence and that we are using it appropriately. I would say that researchers should care about implementation, whether they are implementation scientists or not. And that goes back to the idea that implementation science is on the translational research spectrum. So those people that are doing basic science research or they're doing clinical research should care about whether their discoveries actually reach patients. And so even if they're not doing implementation research, they should want to understand how what they find will actually get into practice. Clinicians should care about implementation because we come to work wanting to deliver high quality evidence-based care. I would say that payers and health systems, the agencies that fund healthcare, are interested in delivering value. Certainly, if they are financing healthcare, they want to make sure that those dollars, that those resources are well spent, and so they also care about implementation. And then finally, regulators care about implementation. There are agencies that oversee the provision of healthcare. They're necessary to make sure that we are delivering on the promise of healthcare, and they as well want to make sure that evidence-based care is being practiced. This is my favorite cartoon about implementation. It says, it's got two soldiers there on a battlefield, and one says, "I've never actually stormed a castle, but I've taken a bunch of siege management courses." And the idea here is that it's one thing to talk about implementation, but it's another to actually think about it, study it in a rigorous way, and to be systematic about it. And so I'd like to share with you some of the ways that we think systematically about implementation. This is a cognitive aid that I developed with some colleagues, with Renad Baitis, who is my partner in crime at the University of Pennsylvania with respect to implementation science, and then Jeff Curran, who is the father of the hybrid effectiveness implementation trial, and he's based at the University of Arkansas. And the three of us teach implementation science. There are many trainees who are coming up now and they want to know about implementation science, what it means, what the implications are for their work. And one of the questions that we get repeatedly is my thing implementation science? Is my study implementation science? Or is the thing that I'm interested in amenable to study with implementation science? And so what we did was we created this subway or metro map. So if you've been on a metro in London, Paris, Washington, D.C., New York, hopefully this looks a little bit familiar to you. The idea is that you start off in the left side here and you identify what your practice of interest is. And it could be enhanced recovery after surgery. It could be active warming in the perioperative period. It could be goal-directed therapy. Pick an evidence, pick a practice. And then you ask yourself, has it shown efficacy? In an idealized setting, in a randomized control trial or some other sort of gold standard setting, does it work? If the answer to that question is no, then you figure that out. That's not implementation science, that's efficacy research. You do want to design your interventions to be implementable. And increasingly, we as implementation scientists are helping intervention developers think about how to create implementable interventions. So as an example, if I were working with an infectious disease specialist and they were developing a new antibiotic, I would say, don't make an antibiotic that's IV 6 times a day, right? That's not implementable. That makes no sense. That's in clinical practice going to be very difficult to do. So even though we're not studying implementation, we can still keep implementation in mind as we're designing our interventions. But let's say your practice of interest has shown efficacy. You know that it, in theory, from a mechanistic perspective, it works. So then you ask yourself, has it shown effectiveness? Does it actually work in the real world, in less tightly controlled settings? If the answer is no, then you can do that effectiveness research, and that puts you sort of in the upper right corner there. But if the answer is maybe, sort of, kind of, then you can do what's called a hybrid effectiveness implementation trial. Increasingly, people are doing this even when they have no evidence of effectiveness, because it's so clear that we need to understand implementation as early as possible. And so there are some people that would suggest that every effectiveness study should be a hybrid effectiveness implementation study. And perhaps when we get to the question period, we can talk a little bit more about that. When I logged on earlier today, I heard the discussion about norepinephrine versus phenylephrine, and is there evidence for one versus the other? And this is something that you could study in a hybrid effectiveness implementation trial. So you could ask yourself the question, is one more effective than the other? But at the same time, you can ask yourself, what would get in the way of using norepinephrine preferentially versus phenylephrine versus metaraminol or some other drug? You can ask yourself the question of how might you get people to change their behavior, and that would be a hybrid trial. Finally, if you know that the thing works, if there is sufficient evidence, you're not asking yourself the question anymore about does it work? The questions are, how do you get people to do it? Then you're squarely in the realm of implementation science in the lower right corner there. And so you're doing studies to understand context, to understand barriers and facilitators to implementation. You're designing and testing implementation strategies. And that is where I spend most of my time thinking about how to get people to change their behavior. Implementation, as I'm sure you all know, can fail in many ways. And there are systematic ways to think about implementation, to support implementation. One of them here is the RE-AIM framework, which stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. But I'll share with you a couple of other theories, models, and frameworks that we tend to use to understand implementation. There are a few rules of engagement, as you may start to understand. So implementation science requires that you have an evidence base or tension for change. And so if you talk to someone who is dogmatic about implementation science, who is a purist, they will say, if you don't have multiple randomized trials, you should not be doing implementation science. That used to be more of what we talked about, but I think there is an understanding that we are not always going to have that standard of evidence. I think that there is a movement in our field to generate high quality evidence, multi-center evidence, and certainly the folks that run this conference are a big part of that movement, which is great. At the same time, there may be a tension for change and a tension to move forward even without that evidence. But you need something. You need someone to say, this is ready for testing. If you don't have that, then you're back in the efficacy research sort of realm. Examples of evidence-based practices in perioperative medicine, we could think of many of them. We could think of quantitative neuromuscular blocker monitoring. We could think of postoperative nausea and vomiting prophylaxis, active warming I mentioned, or enhanced recovery after surgery, which this audience knows well. There are many evidence-based practices that we could think about examining with an implementation science lens. The next two things that you need in implementation science are contextual understanding and stakeholder engagement. And the idea here is that when you are implementing, you are not implementing in a vacuum. There are contextual factors that affect whether people are able to do what you want to do. And so if I were to say, you need central line in order to infuse norepinephrine, there are places where they're not going to be able to place a central line. And so that's a barrier to implementation. We would have to understand how to get people to use norepinephrine through some other line, like a peripheral line. But we can't make broad statements, pronouncements about how things ought to be implemented without understanding local context. So contextual understanding is a key feature of implementation science. Stakeholder engagement is related to that. It's understanding the perspectives of the people and the systems whose behavior you're trying to change. You can't change someone's behavior unless you understand what their tensions are, what their priorities are, what their level of knowledge is. And so again, this speaks to the idea that we are not in a vacuum, and we have to understand what the on-the-ground conditions look like before we can improve and promote implementation. So there are 4 takeaway points about implementation science. So I told you if you were going to remember one thing, remember that implementation science is a thing. If you're going to remember a few other things, remember these 4. So the first is that implementation science relies on theories, models, and frameworks. This is a key part of what we do. I am an NIH grant reviewer in the States, and if I see an implementation science grant, I am looking for a theory, model, or framework, and I will be very suspicious if I do not see one. And the reason that we rely so heavily on them is because they structure our thinking about what might otherwise be a little bit fuzzy. And we use a lot of mixed methods. That's point number 2, qualitative and quantitative methods. But the theories, models, and frameworks help put some structure around some of the qualitative data that are so vital in implementation science. Point number 3 is that implementation science has its own set of outcomes above and beyond effectiveness outcomes. And the 4th point I've already alluded to, effectiveness and implementation can actually be studied at the same time. And some folks would argue that they ought to be studied at the same time. So I'll give you an example of an implementation science study. Our group uses implementation science to study and standardize postoperative ICU handovers. So this is a representative picture of what we are trying to achieve in our work. When a patient goes from the operating room or the operating theater to the intensive care unit, we expect that there is a bedside handover that discusses that patient, what they've been through, and what the expected postoperative course looks like. That expectation comes from more than 60 published studies that have looked at this phenomenon and have all settled on structuring the handover as a tactic to improve information exchange and to decrease preventable adverse events. So this is our thing. This is our practice of interest. This is the starting point in the subway for us, is this bedside group handover process. What we use one of these theories, models, and frameworks. The idea here is that we have an evidence-based practice, which is this protocol. We use implementation strategies to get people to do the protocol, and those implementation strategies can focus on the clinician, they can focus on the team, they can focus on the ICU or the hospital. Once we deploy those strategies, the outcomes that we look at are related to implementation, to process, and to effectiveness. And so I won't go through this in detail, but the idea is that we are trying to relate implementation to outcomes. And so hopefully you can get a sense of how implementation and effectiveness outcomes sort of work together to help create a robust understanding of a phenomenon. So I'll walk you through how an implementation study might unfold. And so this again is looking at that operating theater to intensive care unit handover process. Here I'm using a framework called EPIS, which is exploration, preparation, implementation, and sustainment. And I'll walk you through the questions that we ask at each stage to give you a sense of how an implementation study might unfold. So the first question we ask ourselves is, how are these handovers conducted currently? So this is contextual inquiry. And are people even ready for change? So we watch what people do, we talk with them through interviews and focus groups, and we look at their documents and artifacts that they create. Once we have a sense of what is happening now, then we can start to prepare a standardized handoff process. So we can take what we know from evidence and we can tailor it to match the setting, synthesize this literature into something that's usable, and then do some prototyping that fits that actual clinical environment. Then we ask ourselves, how do we get people to change their behavior and adopt a new way, in this case, of doing handovers? And so our implementation strategies were largely training and evaluation and coaching, but depending on the setting, you might use different strategies. And then in the sustainment phase, we ask ourselves, how do we get people to, or do clinicians actually exhibit fidelity over time, where fidelity is the concept of adherence? Do people continue to do this thing over time, ideally without active maintenance? And so that process looks a lot like the contextual inquiry phase. Implementation strategies are the key ingredient to this. These are the how of implementation. This is how you get people to change their behavior. And there are a lot of ways to talk about implementation strategies, but I like this way of breaking it into 6 basic categories. Are you planning the process in a very deliberate way? Are you educating people? And certainly in healthcare, we love education. Are you restructuring the clinical environment or restructuring expectations? Are you managing or altering quality in some way? Are you changing financing, or are you changing healthcare policy? And this is just a sampling of the individual strategies that you might use. There are actually a lot more. I'd show you this just to say there are a lot more. This is the obligatory overwhelming slide. There are a lot of implementation strategies, and part of the finding context and understanding context helps us, that's necessary to figure out which of these strategies we actually deploy. So that's complicated, right? There's a lot going on here. And so you might ask yourself, what do you actually measure in a study focused on implementation science that might have so many moving pieces? So in our study of postoperative handovers, these are the outcomes that we studied. And what I want you to focus on is that there were 2 types of measures. So effectiveness and implementation, because we were doing a hybrid effectiveness implementation trial, where the effectiveness question is, does structuring handovers actually work? Does it improve information exchange? And does it improve patient outcomes? The implementation questions were, how do you get people to do it? You'll also see that we were a mixed method study using qualitative and quantitative data. And so there were quite a lot of outcomes. We did have one primary outcome, which was information omissions, which was an effectiveness outcome. So I told you that implementation science uses mixed methods. I told you that it has its own implementation outcomes, and I told you that you can study effectiveness and implementation together, and you can see if you look at all of our outcomes that those concepts are all reflected here. So I told you about hybrid effectiveness implementation trials. The reason that we do them is because there is a time lag between phases of research, as classically conceived. If you do efficacy research, you write it up, someone reads it, they go, oh, I should study effectiveness. They do the effectiveness research, they write it up, they say, oh, we should figure out how to get people to implement it. There is a time lag between each of these phases of research, and that time lag can be on the order of decades. So if we actually want evidence to get into practice, we need to figure out a way to smush them together, and that is the point of the hybrid trial. Again, you've seen the subway. The hybrid trial is over in that no partial area. This is where we're still trying to generate evidence around effectiveness and implementation. I mentioned mixed methods. So for those of you who are unfamiliar with mixed methods, this is using qualitative and quantitative methods together. When you're doing mixed methods research, the watchword, the catchphrase is 1 + 1 = 3. The idea is that you learn more from mixing methods than you do from studying either in isolation. But when you're mixing methods, you have to think about how to mix them in a meaningful way. And so when I review papers for journals, for instance, and someone says, we did a mixed method survey, and they talk about how they asked quantitative questions and then they had open-ended questions, I say, well, that's not mixed methods, that's multi-method, because you've done qual and quant, but they're not actually talking to each other. When you're doing mixed methods, you are using one to understand the other, to extend the other, to inform the other. And there are a lot of ways that you can do that, either concurrently or sequentially, and you can do it so that they are equally important, or you can have a mostly qual with a little bit of quant, or mostly quant with a little bit of qual. So I show this figure just to say, when you say mixed methods and you think about mixed methods, there's a little bit more work that needs to be done about exactly why and how you're going to do those mixed methods. But mixed methods are key. Qual is key in implementation research. And that's because, there's a lot of reasons actually. We're trying to build theory about how to get people to change their behavior. We're trying to answer why questions. Why do people behave the way they do? Why don't they do the things we want them to do? And when you are asking why questions, qualitative approaches are much more powerful than quantitative approaches. Quantitative can tell you how much, how often, but it can't tell you why. And so that's one of the reasons that qual is so important here. Qualitative inquiry also helps us characterize phenomena that are not countable or difficult to count. So in implementation science, I think about context and climate. Now, there are quantitative context and climate measures, but they are limited. They're limited in terms of what they cover and the methods that we use to characterize them. And so in my work, even when I use quantitative measures of these concepts, I'm also using qualitative measures because there's some additional richness that is lost in the quant that you can get with the qual. And finally, in implementation science, we do not have a lot of validated measures. So I've mentioned we have specific outcomes like fidelity and feasibility, but exactly how you measure that consistently across studies is still being worked out. And so the qual approaches help you understand a little bit more about those concepts. I mentioned these specific outcomes that we focus on. I'm going to highlight a couple of them here just to give you a sense again of how different, how specific these outcomes are. So these are the classic 8 implementation outcomes that were advanced by Enola Proctor and colleagues. I'll highlight a few of them here because you'll see how different they are from effectiveness measures. The first one I want to highlight is acceptability, which you can think of as palatability. It's how acceptable this intervention is to the people that want to do it. So if you think about enhanced recovery after surgery, is that acceptable to the surgeons? Is that acceptable to the anesthetists? Do they actually want to do this thing? Understanding that will give you some insight into how you get people to change their behavior. If they deem it acceptable, then it's going to be easier and you can focus on other barriers to getting people to change their behavior. But if they don't like it, you have to start there. You have to figure out why they don't like it and hopefully change hearts and minds. And so acceptability is that concept. Appropriateness is another outcome that I like to study, which is perceived fit. How appropriate is this for the environment? So if you think about active warming measures, for instance, if you are in an outpatient setting where each procedure is half an hour long, is it appropriate to worry about all of the extra things that come along with active warming and the warming blanket and all the things? I will leave you to decide that, but when you're trying to get people to change their behavior, you want to figure out, does the thing that you have in mind actually fit in the environment, in the workflow? Does it make sense? If it doesn't, then you may need to address fit before you address anything else. Feasibility is doableness. How possible is it for this to happen? Here I think about the care that we render in high-income versus low and middle-income countries. We can say, oh, well, you need to have an esophageal Doppler monitor to measure flow, to measure cardiac output as a proxy for cardiac output. Can you do that in a place where electricity is not consistently available? Probably not. So when you're thinking about implementing, you want to think about feasibility in a local setting. And then finally, fidelity is really one of the key outcomes for implementation. Do people actually do the thing that you want them to do? So going back to enhanced recovery after surgery, do people actually adhere to the decreased fasting interval or the minimized fasting interval? Do they actually give the amount of fluid that they're supposed to give? Do they get people up and moving quickly? That's fidelity. So all of these can come together in a study. So we in our Handover study studied effectiveness, which gave us lots of numbers about whether people were, transmitting handover communication the way they were supposed to. We had fidelity measures that were quantitative, and then we have implementation measures that are qualitative, where people tell us why they think what they think and why they behave the way they behave. And so all of these things can fit together in the same study to give you a very full, robust understanding of a phenomenon. There is a global interest in implementation science because I think there is an understanding that we are hamstrung or constrained by not being able to get things into practice, evidence into practice. We know so much, but we don't know how to get people to do it. And so globally, you'll see that there are folks that are interested in this field. There are some controversies that I want to leave you with in the last few minutes. Equity is really important in implementation science, and it is increasingly understood to be a challenge. When we think about, I'll go back to the example of high versus low and middle income countries, are we, when we generate implementation evidence, incorporating everyone's perspectives? Are we bringing everyone along, or are we leaving folks behind? So if we generate implementation evidence in places that are highly resourced, we have not spoken to the reality on the ground in low and middle income countries or in lower resourced settings. And so we carry the risk of generating yet another evidence to practice gap. So instead of an efficacy to practice gap, we're now generating an implementation evidence to practice gap. And we haven't actually improved health to the extent that we could if we don't consider equity in the work that we do. Additional sticking points, the evidence to practice gaps apply not just to low resourced and high resource settings, but also thinking about community settings versus academic settings. There are many different gaps that we could generate that we have to pay attention to. One of the sticking points is the level of evidence needed for an implementation study, and I think this is something that's particularly salient to anesthesia and perioperative research because our evidence is not always the strongest, and so the question about when is it ready for implementation is something that we have to think about quite a lot. And then the final sticking point I'll highlight is contextual adaptation. And when does contextual adaptation go too far? If there is a evidence-based thing and we tweak it a little bit to fit in a setting, that's allowable in implementation science, but how much tweaking happens before it becomes a completely different practice? So if I'm doing a structured handover, is it okay that the surgical resident is there as opposed to the attending physician? Sure, that seems fine, but what if it's not a surgeon at all? What if it's someone else? Is that still the same intervention, or is that something different? And I don't think we have a very succinct answer for that in implementation science. So again, there is one takeaway point for you here, that there is a field that's devoted to developing and testing strategies to change both clinician and organizational behavior, and that field is implementation science. My concluding thoughts for you are that we should be thinking about using implementation science approaches to help with the uptake and sustained use of evidence-based practices in perioperative medicine, including stopping doing things that aren't effective. So preoperative testing for certain low-risk procedures would fall in that category. So we can think about both getting people to do things and getting them to stop doing things. And then the second point is that implementation and effectiveness can be and probably ought to be studied at the same time, especially for interventions that are new. So I'll thank you for your time and attention. That brings me to the end of my remarks, and I think that we have a question and answer period. So thank you.
Meghan, thank you so much. That was a really great presentation, and I think it's something that, frankly, I think all our trainees and colleagues should see. I just shudder when I sort of look back and think about some of the audits we've done on handoffs, as you and probably, frankly, the wasted effort from very well-intentioned people because there wasn't a framework there wasn't a kind of understanding of how that was going to be made better other than a general goodwill to try and make it better. So, I've learned a lot, and
thank you
really
very much.
Appreciate the lecture.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.